pregnancy, followed by the topic about the diabetes in pregnancy updated guidelines. We'd like to introduce and welcome Dr. Chitra Jha, the senior consultant and the head of maternal medicine at Royal Hospital.
Rania is talking first.
Dr. Rania first?
Dr. Rania first, Doctora.
Yeah. Okay, sorry about that. So we'll start with the Dr. Rania. Dr. Rania Abdulraz, she's a consultant for the maternal medicine, medical disorder, and the high-risk pregnancy, running mainly specifically for diabetes in pregnancy. Dr. Rania will update us about the recent guidelines about the diabetes in pregnancy, mainly important guidelines, the criteria to diagnose diabetes in pregnancy for the gestational diabetes, and when to refer the patients and the antenatal managements. Dr. Rania would like to invite you and introduce you to the start the presentation.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening for everyone. Thank you very much, Dr. Shamsa, for this introduction. Today, I'm going to talk about diabetes in pregnancy. Mainly, I will highlight the recent guidelines which are updated by the Maternal and Child Department in the Ministry of Health, which is done in May 2022. In this presentation, I'm going to put small introduction, then types of diabetes in pregnancy, the adverse outcome of GDM in pregnancy, treatment of pre-existing diabetes when planning pregnancy, which mainly preconceptional, counseling, gestational diabetes mellitus, risk factor for GDM, screening, how to screen, and what is the diagnostic test which we are taking in Ministry of Health guidelines for GDM, management of GDM and over diabetes, and peri and postpartum management of GDM and diabetes, and contraception, and follow-up and prevention of type 2 diabetes mellitus. As all of us knowing that due to increase the obesity all over the world, there is increased risk of type 2 diabetes in the women of childbearing age. That lead to increase the number of pregnant women with undiagnosed type 2 diabetes. So obese women become pregnant, then have higher risk of developing GDM. What the types of diabetes in pregnancy? We have diabetes detected during pregnancy, and pre-existing diabetes mellitus. Diabetes detected in pregnancy, we have two types, GDM, which is the abnormal glucose tolerance with the onset or first time diagnosed during pregnancy. And over diabetes, it is the diagnosis of over diabetes can be made in the women who meet any of the following criteria: if her fasting plasma glucose more than or equal to 7 millimole per liter, and random plasma more than or equal to 11.1 millimole per liter, or her glycated hemoglobin is more than or equal to 6.5%. There is some confusion between, we saw many referral, it is GDM or over diabetes. So this how to differentiate between over diabetes and GDM. Then the pre-existing diabetes mellitus, which is covered by type 2 and type 1 diabetes. Type 2, it's caused by insulin resistance or relative insulin deficiency, and it is often associated with obesity, which is more common in nowadays due to pandemic of obesity all over the world. Type 1 diabetes, it's caused by absolute insulin deficiency with positive autoimmune markers, such as which is destroying the beta cells in the pancreas. So this patient, usually they are positive for anti-island cells antibodies, anti-JAD antibodies, and low C-peptide. And they will have also history of diabetic ketoacidosis. So what is the complication of diabetes in pregnancy? There is increased risk of miscarriages, which is more frequent with pre-existing diabetes mellitus than the GDM. Increased risk of congenital anomaly, which is more with also pre-existing diabetes than the GDM. Preeclampsia, polyhydramnios. There is risk of fetal microsomia, which is more in GDM than the pre-existing diabetes mellitus. Also, there is fetal micromegaly, like hepatomegaly, cardiomegaly. There is risk of birth trauma of the baby, perinatal mortality for the mother, for the baby, neonatal respiratory problems, and metabolic complications like hypoglycemia, hyperbilirubinemia, and hypocalcemia. And they are also increased risk to develop the diabetes in their childhood. So The risk of complication over diabetes is twice as much as GDM. Pre-gestational diabetes and over diabetes is more associated with congenital abnormalities, and GDM can lead to more macrosomic and premature deliveries. Now, if we talk about treatment of pre-existing diabetes mellitus when planning pregnancy, that's mainly in the preconception period. So if the patient, she is already diabetic and she's planning to get pregnant, how we can guide her and what is advice we can give. First of all, regarding her glycemic control, we should achieve blood glucose and glycated hemoglobin level within or close to the normal and avoid hypoglycemic events. So obese women should also, that's our principle. So first of all, to achieve blood glucose and glycated hemoglobin near or within normal level, avoid hypoglycemic attack, and obese lady, usually you should advise them to weight reduction before planning for next pregnancy. In the women with insulin therapy, it's very important to shift them to multi-dose regimen. It is a good option for them, and it is more flexible for change their dosing according to their blood glucose levels. As we know, the insulin dose may need to be increased as the pregnancy is advanced, so we will need to frequent visits, frequent follow-up to titrate their hemoglobin, to titrate their insulin according to their blood glucose levels. In the first, as we know, in the first trimester, due to reduce in total daily insulin requirement, so the women should be more high risk for increased hypoglycemic attack. So we will educate her more to take small frequent meals, and we will adjust her dose. In the second trimester, rapidly increased insulin resistance required weekly or bi-weekly adjustment to increase her insulin dose to achieve her glycemic targeting. And we also will advise her if she is in oral hypoglycemic agents preconception. If she got pregnant, all oral hypoglycemic agents should be stopped except metformin, which she can continue on. We advise them to be in folic acid 5 grams OD, to be supplement 3 months preconception, and to continue after pregnancy till breastfeeding period finished. If diabetic patient who plan to get pregnant, she should get retinal assessment. Baseline assessment of diabetic retinopathy is recommended, as women with established retinopathy should have retinal assessment done once in each trimester because of the risk of a progression of the retinopathy during pregnancy. While rapid implementation of tight glycemic control in the setting of retinopathy is associated with worsening of retinopathy. So every lady who is planning to get pregnant, she should have her retinal assessment before getting pregnant, and should be repeated in and if she have retinopathy, she must recheck. But if she doesn't have any retinopathy, no need to recheck every trimester. She will have it once at booking, then according to her status. Renal assessment. All diabetic patients who plan to get pregnant, they should have their renal function and to measure their urine albumin creatinine ratio, serum creatinine, estimated GFRs before conception. As if there is any nephropathy, to be referred to nephrologist. And usually we are referring them if serum creatinine more than 120 unimole per liter or estimated GFR less than 60 milli per minute. Usually diabetic patients, some of them, they are also chronic hypertensive. So we should educate them pre-conception. If she is in antihypertensive medication, she should be well control her blood pressure. And we are advising her if she is become pregnant to stop her medication and to be shifted to the medication which is more properly at pregnancy. So as AC inhibitor, angiotensin receptor blockers should be replaced with safer medication like methyl-dopa and labetalol. And every woman who is diabetic, she should have thyroid function test prior to her conception, planning to get pregnant, because if she is hypoglycemic or hypothyroidism, or she has some other problems to be treated before getting pregnant. So what is the checklist for pre-existing diabetes? First, she should attain a preconception level of glycated hemoglobin less than 7, assess and manage any diabetic complication prior to pregnancy, shift to multi-dose insulin in patient with pre-mixed insulin, achieve good blood pressure control with safe anti-hypertensive medication. She should be in folic acid 5 mg OD 3 months preconception. Discontinue any potential teratogenic medication as EC inhibitor or ARBs or statins. We will go now to gestational diabetes. We define the GDM as a condition associated with maternal hyperglycemia, less severe than that found in the patient with overdiabetes, but it is associated with an increased risk of adverse pregnancy outcome. Pregnancy is characterized by insulin-resistant and hyperinsulinemia. So the resistance results from placental secretion of diabetogenic hormones, as well as increased maternal fat deposition, which due to decreased exercise and increased caloric intake. So GDM occurs when the pancreatic function is not sufficient enough to overcome the insulin resistance created by changes in diabetogenic hormones during pregnancy. Any pregnant lady, when she is going to her booking in health center or in a private clinic, to open her green card, here we are talking in Oman, she should be reassessed for risk factor of developing GDM. So we can divide them to low risk and high risk. The high risk patients who have one of this, if her BMI more than 30, past history of GDM, first degree related with diabetes, previous history of macrosomic baby more than or equal to 4 kilograms, history of a previous unexplained IUFD, women with polycystic ovary syndrome. This patient who with polycystic ovary syndrome, most of them, they are already in metformin, especially if they are for treatment of fertility. So we should stop metformin and then give her a gap and then to do her screening test. Glycated hemoglobin more than or equal to 5.7%, or she is diagnosed before as impaired glucose, fasting glucose, or impaired glucose tolerance on a previous diabetes screening test. Other clinical conditions associated with insulin resistance, like severe obesity or acanthosis nigrans. So if after we divide the patient to high risk and low risk, what we are gonna to do? Usually we have our screening and diagnostic tests, which we are using in Oman, which according to the International Association of Diabetes and Pregnancy Study Group and American Diabetes Association, we are taking criteria for positive 2 hours 75 gram oral glucose tolerance test or equal to 5.1 millimole per liter, and or 2 hours post glucose is more than or equal to 8.5 millimole per liter. So we diagnose for that's our screening and diagnostic test in ministry with what you are using in Oman. This graph, it is showing us if the patient she is coming for booking, first of all, usually they will do for them blood glucose if it is random or fasting. So if fasting blood sugar less than 5.1 millimole per liter or random blood sugar is less than 7 millimole per liter, we should first of all categorize them. Is she low risk or high risk according to the list which I put before? If she is low risk, so we will not do any screening test for her for GDM, and we will do at 20 to 24 weeks of gestation to do for her OGTT. If she is high risk for GDM, we will arrange to do one OGTT. And if she is doing OGTT, then we will, if her, as we mentioned, if it is positive OGTT, that's mean if her fasting blood glucose more than or equal to 5.1 and or her post glucose blood sugar is more than or equal to 8.5, we call it positive test. That means she is diagnosed as GDM. If it is not, that means she will go again and repeat her OGTT at 22 to 24 weeks of gestation. So if if fasting blood sugar is 5.1, this we will take. If her random blood sugar is between 7 to 11, we will again arrange for OGTT and we will go with the same algorithm. If it is positive, that means she's GDM. If it is negative, to repeat her test 22 to 24 weeks of gestation. If fasting blood sugar, it's 5.1 to 6.9, no need to do OGTT. That means she's GDM, she's diagnosed as GDM. Then we will start educating her regarding her journeys for GDM. First, we will refer her to dietitian, and usually the dietitian, they are available in all local health center, and they will sit with the patient, they educate them nice, and they calculate their calories, and they will educate them regarding the amount and the quality and quantity of their diet. And this will be done also, and they will have then all patients, they will be explained by family physician in the local health center how to do their blood sugar profile, and they will give them another appointment at least 2 to 3 weeks after proper control diet, and they will see them and target capillary blood glucose values. If it is, we are taking this values, preprandial, it is less than or equal to 5.1, and postprandial, it is less than or equal to 6.7. So if the patient is well controlled and her blood sugar profile within accepted level, she will continue on her diabetic diet. And the majority of GDM, they are in this category, which is controlled by diet. But if her blood but if two blood glucose values are still high, we can initiate oral hypoglycemic agent with the diet control. So it is according to blood glucose level. And if it is still, we are start metformin, usually metformin, we are starting it slowly by 500 BID or TID dose to 2 to 5 days to avoid side effect, especially gastrointestinal side effect of the patient. Then we will review her within a week, and we will adjust her dose according to her blood sugar profile. And the maximum dose we are using during pregnancy is 2.5 grams per day. If we use the maximum dose of metformin and still she is uncontrolled, we will refer her to obstetrician and diabetologist, or to combined clinic if it is available in polyclinic, or here we are running one clinic in National Diabetic Endocrine Center weekly with combined clinic with diabetologists. That to review her diet, to review her medications, and possibility to start her in insulin. If at booking her blood sugar is fasting blood sugar more than 7 millimole or random blood sugar more than 11.1 millimole per liter, that means she is diagnosed as overdiabetes, and we will go with the treatment. This patient is like type 2, so we will refer them to a combined clinic for assessment and follow-up. So the management of GDM of overdiabetes, first of all, it is management of lifestyle, diet. We should proper diet with exercise, and usually we advise them to walk at least 30 minutes per day according to ADA. And we explain to them how to do the monitoring for their blood sugars, and explain to them the target, as I mentioned before, the pre-meal 5.3 and post-meal less than or equal to 6.7. Regarding medical therapy, the oral hypoglycemic agents, it is the metformin, which I spoke about it before, and usually we will put them in aspirin, 75 or 150 milligram from 12 weeks of gestation, and to be stopped around 36 to 37 weeks. And injectable which is insulin. None of the current available, usually the insulin, we are using short-acting, long-acting, or ultra-short. Lizibro, insulin H, insulin R, and Glargine. All of them, it is category V, except Glargine is category C. None of the current available insulin preparation have been demonstrated to cross the placenta. Approximately 15% of the women who are GDM require insulin therapy because target glucose level is exceed despite they are being in dietary therapy and metformin. From 10 to 14 weeks of gestation, that's our principle when we are treating with insulin, period of increasing insulin sensitivity. So insulin dosage maybe need to be reduced according to avoid hypoglycemic attack. From 14 to 35 weeks, this insulin requirement typically increases steady, so they will need weekly or bi-weekly adjustment of their insulin doses. More than 35 weeks of gestation, insulin requirement maybe level is off or it's become more as steady, so they will need less frequent visit. Maybe it is once a week to adjust if needed. We should put in our mind in severe obesity, usually the dose of insulin, it is around 1. It is different from first to second trimester. It's around 0.7 international unit per kg in the first trimester, 0.8 and 0.9 to 1 in the third trimester. With obese lady, maybe we'll increase it to reach around 1.5 to 2 in units per kg to be able to overcome the combined insulin resistance of pregnancy and obesity. We should avoid hypoglycemia as frequent as we can, as it can associated with intrauterine growth restriction. So in labor and postpartum, how we can manage the diabetic patient? The principle, it's all same. Maternal hyperglycemia should be avoided during labor to reduce the risk of fetal acidosis and neonatal hypoglycemia. Maternal glucose level should be kept between 4 and 7. Usually in GDM who are in diet and metformin, they will not need any further insulin infusion or sliding scale. Mainly the pre-existing diabetes, maybe they will need to be in the sliding scale to avoid hypoglycemia and hyperglycemia and to maintain their blood glucose level between 4 to 7 millimole per liter. The women should receive glucose during labor in order to meet the high energy requirement. A routine IV dextrose and IV insulin protocol may be helpful if needed. Postpartum, we should encourage women to breastfeed after delivery because that will help her to maintain her and to control her blood glucose. Metformin can be used during breastfeed because GDM may be present, pre-exist and diagnosed type 2 or even type 1. And women with GDM should be tested for persistent diabetes or pre-diabetes at 6 to 12 weeks postpartum with the same glucose, OGTT, which is 75 gram of glucose. But the value will be changed. I will talk about it later. For those with type 2 diabetes, advised to continue pre-pregnancy insulin doses and should be weekly or bi-weekly adjusted because her requirement will be reduced due to her if she is breastfeeding to avoid hypoglycemic attack. Both metformin and intensive lifestyle intervention prevent or delay progression to diabetes in women with a history of GDM. We recommend that all women who have had GDM to be counseled on lifestyle measures to reduce the risk of type 2 and the need for regular diabetes screen, especially before any future pregnancy. After in postpartum period, we should discuss with the lady regarding the contraception and not to get pregnant unless she is ready for that, as we mentioned with the pre-conception counseling. So what contraception she can use? Any type of contraception is acceptable. Low-dose estrogen, progesterone, oral contraception may be used in the women with history of GDM as long as there is no medical indication. Future risk. These patients are at high risk for recurrent GDM, impaired glucose tolerance, or overdiabetes in the subsequent 5 years. Recurrent, the GDM, 1/3 to 2/3 of the women with GDM they will have GDM in their subsequent pregnancy. So we should also consider them. And all women with the previous GDM, she should undergo to another test after delivery, 6 to 12 weeks postpartum, to find out if she's continued to be diabetic or not. But this time the values, it will be different. We diagnose her as diabetic if her fasting glucose is more than or equal to 7 millimole per liter, and or 2 hours post-glucose level is more than or equal to 11.1, and diagnosed as impaired fasting glucose. The fasting blood glucose level, it is 5.5 to 6.9 millimole per liter, or if the 2 hours post-glucose load ranging from 7.8 to 11 millimole per liter. So as we see here, it is different from pregnancy values, which we are taking. We are taking non-pregnant values. So, take-home message. Those with impaired glucose should be counseled about their risk of development of diabetes and referring for proper management. They should have annual assessment of glycemic status. So any lady, she will do her glucose tolerance in 6 to 12 weeks postpartum. Then she should do it annually for her life. Women with normal glucose tolerance should be counseled regarding their risk of developing GDM in subsequent pregnancy and type 2 in the future. Long-term follow-up is very important. Reassessment of glycemic status be taken every 2 years. Thank you very much. I think the questions will be later.
Yeah. Thank you, Dr. Rania, for the very informative lectures. That was a really interesting topic. I will leave with the, I will just request the audience, please, to write down all the questions for Dr. Rania to leave it at the end, and we'll proceed with the next topic with Dr. Chitra Jha, Senior Consultant Obstetric Gynecology, Head of Maternal Unit, Royal Hospital, and running the Joint Obstetric Hematology Clinic, to talk to us today about the current review and summary of the recent updated national guidelines about the sickle cell disease, the thrombocytopenia in pregnancy, and hypothyroidism. Dr. Chitra, please, invite you, please.
Hello. Good evening, everybody.
Good evening.
Yeah. Can you see me? I can't see myself here.
Yes, Doctor, you are in the screen.
Yes,
Okay.
we can see you. Yeah, you can.
Okay, great. So it's a pleasure to be here. I think the aim of this webinar today is to update everybody with the existing national guidelines, which were updated earlier this year. So I've got 3 guidelines to discuss today. And I'm going to do the first 3. Obviously, I can't go into great details in 30 minutes. So I'm going to just focus on the important areas, the areas which are causes of common mistakes, and highlight certain important issues in the first 3 guidelines. And hopefully we will be continuing these, and then we'll present other guidelines later in the future. So let's start with thyroid disease in pregnancy. A thyroid disease in pregnancy, it is an important medical disorder, and it's everybody knows that the thyroid function tests and the investigations during pregnancy are very different from those outside pregnancy. So universal screening for thyroid disease in pregnancy is not recommended, and it is recommended that when a patient is pregnant, targeted screening by doing TSH for all women who are at high risk. And I'll just give you a list of the women who are at high risk who need to have a TSH done. And remember that TSH measurement remains the principal determinant of maternal thyroid status, and it is TSH which should be used to guide treatment decisions and goals. So as you can see, the thyroid functions in pregnancy are quite different from those outside pregnancy. And this down. Okay. And elevations in serum TSH concentration during pregnancy should ideally be defined using pregnancy and population-specific reference range. If TSH is abnormal, then the patient should be referred to the physician or the endocrinologist as available, and of course to the obstetrician, and then further investigations are warranted. So this is a list of women who required thyroid screening. Basically, those who have a history of thyroid disease or who've had some thyroid treatment in the past for hyper or hypothyroidism, type 1 diabetes, those who may already be on treatment, or those who are symptomatic for thyroid dysfunction, and not to forget obesity, history of recurrent pregnancy loss. This list is all there in the national guidelines. You can all refer to it. Now, let me start with hypothyroidism. Maternal hypothyroidism is defined as the presence of an elevated TSH and a decreased serum free T4 concentration during gestation, with both concentration being outside the pregnancy specific ranges. If only TSH is high and T4 is normal, which we see quite often, then that is known as a subclinical hypothyroidism, and that also requires treatment. So both overt hypothyroidism as well as subclinical hypothyroidism do require treatment, because both are known to cause certain adverse pregnancy outcomes. So you will have two groups of women here. One, women who have already been diagnosed prior to conception, and those who may be diagnosed for the first time after becoming pregnant. Now, those who are already diagnosed, it seems that almost 50 to 85% of these women who are on treatment will require to increase their doses during pregnancy. And usually if they are on a dose of say 7 times a day, then you could increase it to 9 doses per week, 7 doses a week, then to 9, or just increase it by a small increment of 25 micrograms of levothyroxine per day. Now, the most common cause of hypothyroidism is autoimmune thyroid disease, that is Hashimoto's thyroidism, where thyroid peroxidase antibodies are detected. And this happens in almost 30 to 60% of pregnant women who have high TSH. And it has been shown that these are the women who are at a greater risk of adverse pregnancy outcome. Therefore, our treatment is going to be based on the TSH levels, as well as whether they are thyroid peroxidase antibody positive or not. So therefore, the recommendation is, not to get mixed up with these cutoff values. If the woman has a TSH of more than 2.5 milliunits per liters, she should have a thyroid peroxidase antibody status to be done. If thyroid peroxidase antibody is negative and her TSH is more than 4, then you need to start a treatment for her. However, if the thyroid antibodies are positive and her TSH is between 2.5 and 4, then you need to start treatment. If it's less than 2.5, then nothing needs to be done. If TSH is more than 10 milli-international units per liter, then you start thyroxine, irrespective of the thyroid antibody status. So the same thing is given here in this chart, which is a nice comprehensive chart. Same thing, TSH is more than 2.5, check the antibodies. Antibodies are positive, then you start treatment. If it is between 2.5 to 4, consider treatment. If antibodies are positive, then if the antibodies are positive, then you start treatment. If it is between 2.5 to 4, and if it is negative, then you need to start treatment if it is more than 4. So what is the treatment? The treatment is levothyroxine dose, and I said you need to increase the dose by almost by 25 to 30% in case the patient becomes pregnant. Now, 2SH, you should repeat, measure it again after 30 to 40 days once you have adjusted the dose or you have started the treatment. And once the TSH is normalized, it has come into your pregnancy range, then it should be measured every trimester, and we should keep it within our target range. And now, what is the target? This is another good slide to keep as a memory. In the first trimester, maintain the TSH level at less than 2.5. In the second trimester, maintain it less than 3 milli-international units per liter. So that's simple enough. And you need to increase the dose or reduce the dose depending upon the TSH value. After delivery, most hypothyroid women will need to decrease the thyroxine dose that they receive during pregnancy to the pre-pregnancy dose. These women should be referred to the physician with an early appointment for further follow-up and repeat TSH 6 weeks after delivery. Now, hyperthyroidism is a little more tricky and it's not as straightforward as hypothyroidism. And these women are more at risk. They seem to be more maternal complications. It's less common than hypothyroidism in approximately 0.1 to 0.4% of pregnancies. Remember, it can be physiological in pregnancy due to the high beta HCG levels, especially in multiple pregnancy and molar pregnancy. It can be induced transiently by hyperemesis gravidarum, and that is known as gestational transient thyrotoxicosis. Antithyroid drugs are definitely not indicated, as serum T4 will return to normal by 14 to 18 weeks. And as far as possible, we want to avoid antithyroid drugs because unfortunately, all antithyroid drugs are teratogenic. So follow-up throughout pregnancy should be done at the secondary or the tertiary care. And I would suggest that the antithyroid drugs for these patients should be titrated and monitored by a physician or an endocrinologist, depending on whom you have available. Ideally, if you're seeing these patients preconceptionally and the hyperthyroidism has been diagnosed, treatment should be achieved before pregnancy to achieve a euthyroid state before they become pregnant. And treatment can be in the form of ablation, surgery, or medications. And the commonest cause of hyperthyroidism in pregnancy is Graves' disease. The goal of treatment is use the lowest possible dose of antithyroid medication possible. And we are going to keep the TSH target slightly lower, in fact, than the reference range, and a maternal T4 at the high end of normal. Now here, a subclinical hyperthyroidism, which we see quite often, where the TSH may be low, but the T4 is normal, requires no treatment, because the studies have shown that these are not associated with any adverse pregnancy outcome. The antithyroid drugs most commonly used are propylthyrosol, and the usual dose, the least dose, will be 200 to 400 milligrams, or carbimazole. Now, like I said, both these drugs cross the placenta, and now the recent guidelines have shown that propylthyrosol is a little less teratogenic than carbimazole, though probably carbimazole gives a better control of the thyroid. So the recommendation is to change the patient to propylthyrosol in the first trimester. And then after the first trimester is over, after 12 weeks, she can go back to carbimazole. But I suggest we let the physician do that, because it's not always so straightforward. And in some cases where they are well controlled on propylthyrosol, they may even choose to continue on propylthyrosol. So therefore, instruct the patient that once pregnancy is confirmed, she should see the doctor as soon as possible. Thyroid nodules, they could be solitary and they're usually benign. And besides the physical examination and history, one should do a TSH once a thyroid nodule is seen, and thyroid ultrasound should be done. And these patients should be referred to the physician and the endocrinologist for further management, because if there's a thyroid nodule or a cyst, they may suggest an FNAC to exclude malignancy. So let me move on to pregnancy with sickle cell disease. Sickle cell disease is a group of inherited single gene autosomal recessive disorder, as we know, and it is caused by the sickle gene, which affects the hemoglobin structure. Now, sickle cell disease includes sickle cell anemia, which is HBSS, and heterozygous conditions of HBS in combination with other hemoglobins like HBC and HBsB. Hemoglobin S, when it is combined with the normal hemoglobin, this is known as sickle cell trait. These patients are usually asymptomatic, except for a possible increased risk of urinary tract infections, and therefore sickle cell trait need not be referred and should carry on our antenatal care like any other pregnant woman. So pre-pregnancy evaluation is most important. Ideally, they should have a genetic screening, and they should be encouraged to have the hemoglobin status of their partner determined before they embark on a pregnancy. There's really not much you can do if you find that the husband has got a sickle cell trait, except that she will become aware of the risk of having a baby with sickle cell disease. Because quite often the husbands, they would be asymptomatic, but they would never have had their sickling status tested in the past. The patients we see with sickle cell disease will usually be diagnosed with sickle cell disease from beforehand. Check their vaccination, immunization, hepatitis, encourage them to complete their hepatitis, influenza, meningitis. If these patients are planning a pregnancy, then we know that hydroxyurea, those sicklers who are on hydroxyurea should discontinue it 3 months before starting pregnancy. And I find that most patients know that, and they do stop hydroxyurea if they are on it before they start on their pregnancy. But these are the women who are likely to have more problems in pregnancy, because hydroxyurea started for the high-risk women who have recurrent vaso-occlusive crisis. At booking, if she has not had an influenza vaccine in the last year, please encourage her to take that. Again, if she has not, doesn't know her hemoglobinopathy status, then she should check that. VT scoring should be done. So sickle cell disease is actually comes as an intermediate, in the intermediate group, meaning that they should start thromboprophylaxis at 28 weeks of gestation, irrespective. However, in case they have any other risk factors, which I'll just be coming to, then you may need to start heparin right at the beginning. These patients, of course, are referred to secondary care for review by the obstetrician, and they should ideally be delivered in tertiary care or in a secondary care hospital. Take detailed history of the disease, including any complications, blood transfusions, ICU admissions, any surgeries in the past, because this is going to give you an idea of how she's going to perform in her pregnancy. Is she a woman because sickle cell disease, we find that patients all are not the same. Some run a very mild course of disease due to various reasons, while others have very, very stormy courses of disease. So this is going to give you an idea of what sort of a patient this is, and whether she should be urgently referred to tertiary care and let her have all her antenatal checkups over there. Take a detailed history of previous pregnancies outcome and any complications. Maybe she might even require exchange transfusion during pregnancy. So that's the reason. Baseline checks, of course, a history of any surgeries. Some of them would even have hip replacement in the past, cholecystectomy, splenectomy. Assessment of cardiac function is important because long-standing anemia sometimes leads to pulmonary hypertension. And it's good to know whether she needs an echocardiogram. Baseline investigations, of course, here, serum ferritin, HbA status, urine culture, and antibody status is important because some of them may have antibodies. And that's going to tell you that it's going to be difficult to arrange blood for her in emergency. So probably we need to be aware of these patients who have an antibodies. Also, if they have antibodies because of repeated blood transfusions, some of these antibodies may cause mild hemolytic disease of the newborn. And these are the ones who would also require screening for fetal anemia throughout pregnancy. Check blood pressure and proteinuria, and of course, a booking ultrasound as usual. Now, how are you going to counsel these patients? Provide these women with every possible information about the course of the disease, what are the complications they should expect. I think the best possible advice that can be given to these women is to tell them to go to hospital and seek medical help early in case of any symptoms. The thing is that they are so used to their disease since they were born, and they would take any vaso-occlusive crisis, any pain, normally, and like they're used to doing in the past. However, they need to understand that pregnancy is different and things can deteriorate very rapidly. And therefore, they must go to the hospital in case of any symptoms. Dehydration, possibly due to nausea and vomiting, can lead to precipitation of the crisis, remember that. And also there is a role of, we know that, hypoxia, cold, stress, which could increase the frequency of sickle cell crisis. They are at risk of fetal growth restriction. Genetic counseling, as I have already mentioned before, depending upon the sickling status of the partner, they must understand the disease is likely to worsen during pregnancy, unlikely to improve, it may stay the same. And there are increased risks of chest infection, thromboembolism, preeclampsia. There's no absolute level at which transfusion should be undertaken. And the decision must be made along with clinical findings. The aim is to keep the hemoglobin close to the patient's baseline and to bring it up to about 8 grams prior to delivery. Repeat CBC at each visit, and the results should be carefully followed. Don't forget that, because that's another thing that happens. We may send a CBC and then the patient goes away. It's our duty to check that hemoglobin once the patient is gone. You may suddenly find that the HB was 6 and she would be fine. So she must be called back and she needs blood transfusion. A marginally raised WBC count may be normal for these patients. So urine analysis and culture is done at booking. If the initial culture is positive, she should be treated and then screened monthly. If initial culture is negative, then screen once every trimester. Be alert for symptoms and early treatment of infections, early referral to the hospital. So I want to talk about the drugs here. So all these patients should be started on folic acid throughout pregnancy, low-dose aspirin for 12 weeks onwards for the prevention of preeclampsia. I'm stressing on iron supplementation because we do find that just because she's anemic, doctors start these patients on iron supplements. So they do not require iron supplements, only if there's laboratory evidence of iron deficiency, which is very unusual. In fact, they have high ferritin levels. That's why we did ferritin in the beginning, because of repeated crisis and blood transfusion. So please do not give them oral iron. If they are very anemic, they need blood transfusion because the cause of anemia is hemolysis and not iron deficiency. Penicillin prophylaxis is given only to hyposplenic patients, and we're not giving it routinely now. But low molecular weight heparin, I'm stressing it again, it should be started at 28 weeks. However, there can be other risk factors earlier, such as vomiting, dehydration, immobilization, or hospital admission prior to 28 weeks gestation, when you may need to initiate thromboprophylaxis earlier. They may have had a previous thromboembolic event, in which case they should be started at booking. And postpartum, heparin needs to be continued for 6 weeks, irrespective of the mode of delivery. So in the previous guidelines, they were giving thromboprophylaxis only during hospital admissions, but now this has changed slightly. NSAIDs can be prescribed only between 12 and 28 weeks of gestation. Otherwise, paracetamol, tramadol if possible. It can be used postnatally. Contraception is really important, and I would sincerely wish that all these patients should be counseled regarding contraception and offered appropriate contraception. They should be advised to restrict their families. If they've completed their families, I usually encourage them to go for tubal ligation. Otherwise, Mirena and injectable contraception are the preferred choices. COCs, I know the low dose tablets have a low risk of venous thromboembolism, but COCs are usually avoided, and so are the normal copper Ts and the IUCDs because of the risk of infection. Barrier contraception can be used, but it has a higher failure rate. So I usually encourage them for Mirena or injectable contraception. Remember, deaths due to sickle cell disease are sudden, and all these complications are there. Apparently, sickle cell disease is associated with both maternal and fetal complications and can be a cause of maternal mortality. And it is one of the leading causes of maternal near miss in Oman recently. And some of these complications and deaths actually could have been avoided by early review and early treatment. It is important to treat vaso-occlusive crisis, monitor for early signs of life-threatening events, and don't withhold radiological investigations when they are required. You have to weigh the balances with the risk. If she requires an X-ray chest, go ahead with it. Aggressive management and transfusion, blood transfusion if required. So I'll go on to the last topic, which is thrombocytopenia in pregnancy. And here I'm going to talk mainly about thrombocytopenia in a stable patient. We're not talking about acute thrombocytopenia, which is related to DIC or to HELLP syndrome. So the reason why I'm talking to this, because there are lots and lots of referrals of thrombocytopenia to the clinic. And it is one of the commonest hematological abnormalities which is seen in pregnancy. Remember that the platelet counts in pregnancy are slightly lower than in a non-pregnant woman. And this could be because of the dilutional effect or accelerated platelet destruction, and they could be even lower in twin pregnancy. So mild thrombocytopenia is actually physiological and requires no intervention. So they've arbitrarily divided it into mild, moderate, and severe. However, and the diagnosis I know, the definition I know is less than a platelet count of less than 115 to 10 to the power of 9. But in pregnancy, I would say a platelet count of less than 100 into 10 to the power of 9 is the one which requires further review and investigations. In general, counts that are stable and more than 100 do not require, and I would just suggest that in case you find that it's around 100, a little bit more than 100, 110, repeat it every month. It may just stay the same. But in case it falls below 100, then she needs to be referred to the physician or the hematologist, whoever is managing these patients. This is a lovely slide, which, in brief, gives you all the causes of thrombocytopenia. So we have isolated thrombocytopenia, which could be pregnancy specific or non-pregnancy. So the commonest cause, 70 to 80%, is due to gestational thrombocytopenia. Immune cause could be ITP or secondary to SLE, antiphospholipid syndrome. Don't forget that HIV by itself or some of the drugs which a retrovirus patient may be taking, the antiretroviral drugs, can cause thrombocytopenia. Hepatitis screen also. Then those which are associated with systemic disorders would be preeclampsia, HELLP syndrome, acute fatty liver, TTP, viral infection, which are transient, and nutritional deficiency like B12. So, if you see a patient with thrombocytopenia, severe or moderate for the first time, some of the investigations which you may do to exclude these causes would be a blood film, a liver function test, HIV, which is done for all our patients at booking in any case, immune markers if they are available, hepatitis screen, liver function test, proteinuria, B12 levels. So this will cover all these. And if all of these are negative, then it's a diagnosis of exclusion. That means it's either gestational thrombocytopenia or it is ITP. Before I go on to that, I want to just briefly talk about spurious thrombocytopenia or pseudo-false thrombocytopenia, which is actually false thrombocytopenia, which occurs due to platelet clumping. Now, when we take the sample of blood for the CBC, which is taken in these purple bottles, the EDTA sometimes causes clumping of the platelets. So once the platelets are clumped together, you have a lot of platelets. However, the automated machine does not read it as a thrombocyte, as a platelet, and it reports it as low platelets. So you may need to repeat it by doing a citrated sample, which you send it in another kind of bottle with sodium citrate as the reagent. But remember that even sodium citrate can sometimes cause clumping. The best thing to do is to order a peripheral blood film where the hematologist or the lab technician can directly see the film and tell you that platelets are enough. So if it is pseudothrombocytopenia, then no further treatment is required. That's the important about it. And nobody needs to worry because she has enough platelets. So this is the difference between gestational thrombocytopenia and ITP. Both are difficult. I mean, they both present in the same way, except that in ITP, it is usually chronic, but it may present for the first time in pregnancy. The platelets counts can be very low. Usually it would present a little bit later in pregnancy. Gestational thrombocytopenia, the only way to diagnose it, that it resolves within 6 weeks postpartum. And of course, it doesn't cause fetal thrombocytopenia. The reason why I put this slide, I'm going to finish soon, is because people panic a lot when they see very low platelet counts. So when we look at these patients, we don't start treatment early in pregnancy. In fact, even 20 to 30 into 10 to the power of 9 in the first two trimesters, we don't worry because it doesn't cause any complications. And the patients tolerate them well if the patient is asymptomatic. However, closer to term, after 34 weeks, the aim is to keep the platelet count more than 50 for a vaginal delivery. Nobody knows what is the best platelet count. However, most people have decided arbitrarily that 15 to 10 to the power of 9 is adequate for a safe vaginal delivery and does not cause bleeding. Anesthesia, if she's going to have a general anesthesia, then epidural would require at least 80. For cesarean, you might want to keep it at about 80 to 85 to allow a safe epidural analgesia. So the first line of treatment is usually a prednisolone, and the dose of prednisolone is 20 milligrams per day. We don't increase the dose after that. If she's not responding to prednisolone, then she needs another form of treatment. And this is started, like I said, depending upon a platelet counts and depending on where we are in the period of gestation. So this is a good slide which summarizes the whole discussion about thrombocytopenia. Of course, we have to exclude hemolysis, look for all these causes. If it's platelets is less than 100, then you refer. From 34 to 36 weeks onwards, aim for a platelet count above 50 or 80, depending upon the mode of delivery. And of course, the baby's platelet count needs to be checked after delivery. Don't forget thromboprophylaxis, because ITP, even though the platelet counts are less, but if it's more than 50 and is associated with an underlying immune process, then as usual, we should do a risk assessment. And if she needs heparin, it should be given. Low dose aspirin should not be withheld because the method, the action of aspirin is different, and it should not be withheld unless the risk of bleeding is high. And the key recommendations is we aim to achieve a safe rather than a normal platelet count. Individualized approach is important. Remember, ITP may worsen or relapse during pregnancy. And I think we'll stop now. Thank you very much.
Thank you, Dr. Chitra, for the very interesting, informative, and a good review of all these topics with the pointed and highlighted the important points for each disease. Thank you so much. We will proceed now with the questions and discussion, and I'm going to read. I have a few questions and discussion. I will read one by one. Okay. Can you display for us the question, Zakia, so I can read it one by one? I think I got, I think I got total 6, but I'm seeing only one question. So the first question for Dr. Rania, sorry, this is no name. What about GDM? So I don't know, the question is not clear here and it's not complete. I don't know exactly what.
Victoria, go to the other side that answered questions. I think Dr. Rania already answered it.
Oh, it's already answered?
She wrote the answers, but it would have been nice for everybody to hear.
Yeah,
anyway.
So so everybody can hear and know the answer. So it was answered all. Any question from the audience now? Anybody have a question can raise hand?
They can unmute and they can ask also.
Yeah, if anybody can raise hand and unmute, because I saw initially like 6 or 7 questions, but I think it's all answered. Okay. Dr. Gowri raised hand. Dr. Gowri, please go ahead here. Unmute Dr. Gowri, Zakia.
Yes, Doctor, it's unmuted.
Dr. Gowri, please.
She unmuted herself.
Okay.
We can't hear her.
Dr. Gowri?
I think you need to unmute yourself, Dr. Curry. It's showing as mute.
Okay, can we take any of other participant who raised hand? There is the 3 people raised hand. So who's the first? I saw 3 raised hands. Yeah, doctor, can you introduce Dr. Veena? Unmute yourself, Dr. Veena.
I think they're not able to unmute themselves.
Dr. Veena? Zakia, is it a problem with us or there's a problem here?
No, Doctora. Themselves, they have to remove the unmute. I already allow them.
Okay, can we go to the next then? There's a 4 participant raised hand.
Yes, now I allow Dr. Atika also to answer.
Dr. Atka?
Hello.
Hi, Dr. Atka, how are you?
Yeah, good evening. Thank you very much for this informative talks. My question to Dr. Chira regarding platelet counts for the woman who is gradually dropping the platelets counts, is there any indication to deliver maybe by 38 weeks or 39 weeks due to the dropping of platelets, even if it is within normal, like reaching 100 or 120?
No. If her platelet count is more than 50, then we are okay. If you feel that she's going to drop below 50, yes, they may be in certain conditions, you may allow them to, cause them to deliver. But normally gestational thrombocytopenia are found. If they maintain their platelets count between 60 or 70, then we'll just let them come in labor as and when they want.
So there's no need to induce them by like 38.
Not all patients,
or like that.
Not all. There may be some, like say you have somebody with ITP and you started her on prednisolone,
yes,
and you're finding that she's, it's difficult to maintain her platelet count. You feel she may require immunoglobulin prior to delivery. Yes, we would individualize and probably go ahead and induce. Otherwise, mostly it's okay, depending from patient to patient.
No, I'm talking in general, just gestational thrombocytopenia. So there's no role for induction because of gestational thrombocytopenia.
No.
Okay, thank you.
Thank you, Dr. Atka. We'll go to the next participant. Are we still Dr. Arthi? Arthi? Can you unmute yourself, please?
Dr. Shamsa, there are already another 6 questions in the chat, in the Q&A.
Yeah,
Okay,
I will
read
those,
one by one. So Nadia Nazish, are you supposed to start aspirin at diagnosis in both GDM and over diabetes? Dr. Rania, this question for you. Are we supposed to start aspirin?
Yes, to be an over diabetes patient, yes. And the GDM, which is diagnosed early before the 14 weeks, we are starting.
Okay, the next is for...
And as I mentioned, over diabetes, the values is different, which is very high. We call them over diabetes. It is within just close or near to the values. It is called GDM, the early onset.
And also GDM, is that right?
And definitely the pre-existing diabetes also.
Pre-existing. How about GDM? Also start aspirin?
Yeah.
Both.
A GDM, which is diagnosed early.
Okay. We will move to the next question. Athira. Dr. Athira, patient received dexamethasone for lung maturity at 24 weeks. When can we do GTT if not done already? Dr. Rania.
From 3 days to 4 days, up to 1 week, then to arrange one OGTT for her after 1 week from her DEXA.
Okay, Veena, next question from Veena. Want to ask if patient on low dose aspirin and low molecular weight heparin since early pregnancy with ITP, should we stop then ask for risk of bleeding? I am not sure what is will stop then for
no,
should we stop it as a risk of bleeding?
No. So in case the platelet count, the recommendation is that the platelet count is more than 50 and she needs thromboprophylaxis for whatever reasons, then you can continue it. If she, it doesn't increase the risk of bleeding because you're giving a prophylactic dose.
Okay, thank you. Any other questions from the audience?
I think they
Dr.
want to share the lecture link as we missed the initial part of it. Zoom login was not. I think Zakia can help with that.
Okay, and you can also, if there's few people asking for the lecture slides, if you can forward it or email it to Zakia, Dr. Chitra, Dr. Rania.
Yeah.
And if you can just email the slides lecture, the PowerPoint to Zakia, she will forward it to them. There is a couple of people
I got a
asking.
question regarding polycystic patient,
Okay.
polycystic ovarian, who is already in metformin. When to do their OGTT? Usually, if they are in metformin and because of most of them because of fertility purpose, better to do one blood sugar profile when they are in metformin, and if it is normal, to stop the metformin and to arrange for her OGTT within after 2 weeks from stopping. If it is abnormal, we will take her as over diabetes and to be treated as over diabetes.
Thank you. Dr. Rania, I have a question for you. I read it in one of the articles and I want to confirm about the findings. The long-term use of metformin, does it have any long effect or consequences on the childhood period after delivery for those during childhood?
There is many studies, especially in the metabolic disease.
Yes.
There is many studies. It's working. Some they are agree, some they disagree with metformin. But till now, no specific recommendation have been published.
So does it have any effect on long durations of use later on during childhood on the IQ or mentally elements on the childhood later? I read it one of 2 articles, but I'm not sure, does it really have consequences on that?
Actually, no definite. It is small studies which is not supported, this one. But there is many studies now, it's ongoing, but until now nothing published supporting this. But there is a small studies regarding it and some metabolic disease. But if we wait the use of metformin with the others, I think it's a good drug till now.
Okay, thank you very much. We have 4 participants raised hand. So can we get one of them, please? Who's
There is another question, Doctora, another question, Doctora.
Okay.
In the
Okay,
Q&A.
we'll open the chat and there is a question. I think this one already we Sheila, Bina, the last one already we answered. Which one?
No, Nadia's.
We answer all. Aspirin, asking the dose of aspirin,
no, after that,
75.
after that.
Yeah, Nadia, in diabetic diabetic mellitus, type 2 diabetes, folic acid 5 milligram from preconception period till start of breastfeeding or till 12 weeks? Rania,
12 weeks
Dr.
of
Rania.
what? 12 weeks of what?
12 weeks of gestation. Do you start till the actually it's not clear the question. What I understand, type 2 diabetic, do we need to start folic acid 5 milligram preconceptions period till the puerperium?
Yes.
Or we start from 12 weeks?
No, you stop at 12 weeks.
We will start folic acid 5 milligram OD 3 months before withdrawing the contraception, pre-gestational, and to continue until breastfeeding. And usually it's recommended also to continue during breastfeeding and to stop it just when you are finish your breastfeeding and you are not planning for more. Okay,
thank you. The next question, the dose of aspirin, is it 75 or 150?
This or that, it is same.
It can be either.
It can be 150 or 75 for diabetic patient.
Thank you. Any other question?
Or comment if anybody wants to add something.
Nada, I think Nada raised hand. Who's Nada? Hello, Nada, can you please unmute yourself? We couldn't get Dr. Bina and we couldn't get Dr. Gauri. There is another question, I think number 8. Najla, Yeah, Najla, you can go ahead. Yeah, please ask your question. Najla Al-Aremi,
Yeah,
please
so she
unmute
wants,
yourself.
there's one question here from Iman. Who should correct the levothyroxine dose? So I think thyroxine dose, we can correct it ourselves at the health center or the doctor, because you're going to increase it by small increments. So if somebody is on 50, you could increase it to 75. We don't jump a lot. Usually, if I find that a patient is on a very high dose of thyroxine, say she's already taking 150 or 200 micrograms per day, and in spite of that, her thyroid functions are not, her TSH is not normal, and then I would refer to the endocrinologist or physician to correct the dose. Otherwise, small increments of thyroxine we can make ourselves, and I think everybody in the health center is doing that.
Thank you, Dr. Chitra. So people who cannot unmute themselves, they can just type the question and we will answer it. Yeah, please type the question. Two participants raised hand. Okay. Do we need to refer to endocrinologist if the first time diagnosed during pregnancy, Dr. Chitra?
Which patient?
Thyroid.
Hypothyroid. I think from the hyperthyroid definitely should be referred to the endocrinologist. The hypothyroid, I think the patients who are they are being, once they are seen at the primary health center, I don't know where this question is coming from, then they are referred to the secondary care, and then they are seen by the endocrinologist or the physician, whoever is available, and at the same time they are sending a referral to the tertiary care. We get these referrals at Royal Hospital. And so they are given an appointment at about 28 weeks of gestation, the hypothyroid patient, so they can have serial monitoring for serial growth scans.
Thank you, Dr. Chitra. Nadia, Nadia wants to share the recording and the slides. We already put a notice that is the presentation will be emailed to Zakia, and Zakia will forward it to you all. Okay, Zakia?
Victoria, they can review it online through our YouTube.
Okay, excellent, very good. That's easier. Okay, if there is no other question, would the lecture posted on OSOG site? Yeah, we already said that it will be on the website. Is that right?
Yes,
Zakia?
Victoria, it will be in the YouTube.
Okay.
Chitra, there are 2-3 more questions if you want to do that, or you want to stop.
Yes, yeah, we'll take two more and we'll end here.
They've written them here, so we can just read.
Okay. So
Nadia has
Nadia,
share the
Nadia
recording.
already.
Is there any study done? Is there any study done locally
Hajar.
regarding metformin side effects during pregnancy, which leads patients to discontinue it?
Is this the same? I think Dr. Rania already answered, and she covered it in my question. Dr. Rania, this is almost what you said already. There is not enough study. Is that right? You want to add anything, Dr.
Yes.
Rania?
No.
Okay. And then there's one more. In case of low platelets, aspirin should be continued regardless about platelet level. Yes. In case of ITP and gestational thrombocytopenia, we do continue aspirin regardless of platelet level, unless there's a severe risk of bleeding. I mean, if the platelet count is very low and I feel that there is a risk of bleeding, I might stop it. Otherwise, usually we would continue.
Okay, so at this point, if there is no further questions, so we'll stop at this time, and we'd like to thank Dr. Chitra, Dr. Rania for the very informative, excellent topics, and hope, inshallah, we'll have them in the future again to update us more about the national guidelines, the management, antenatally, intrapartum, and after delivery. Thank you very much, Dr. Chitra. Thank you so much, Dr. Rania, and wish you to see you again next meeting, inshallah.
Thank you. Thank you all for joining in.
Thank you all.
Bye. Good night.
Good night.